Yes.
Okay, wonderful. So thank you, Pramila and the Brain Foundation so much for the opportunity to talk here today. And thank you for the kind and wonderful introduction. Today, I'm going to give some brief background on BioROSA technologies, as well as a recently launched clinical trial that we are in process of enrolling participants for that's entitled a Metabolic Autism Prediction Study. This study is a multi-center, prospective, double-blind, case-controlled trial assessing specific metabolic abnormalities for prediction of autism against the current gold standard in children that are looking for a first-time diagnosis that are currently on a wait list to see a developmental pediatrician. Everyone here is probably very familiar with the autism prevalence rates and costs to society, so I won't belabor too much of this, but for those who aren't or new to the field or just trying to learn, the CDC just updated their recent autism prevalence rates just last week to show that children with autism are believed to be about 1 in 44 children in this country, which is a roughly 241% increase since the year 2000. Unfortunately, since the autism rates appear to continue to be going up, there's no FDA-cleared treatments for autism. The average wait times for receiving a diagnosis continue to, unfortunately, lead to many delays. The cost to society is also skyrocketing as well. This graphic to the right was a recent publication by Dr. Richard Frye and a few others showing estimated costs to society and what that could mean over time for caring for children with autism and cost to the healthcare system overall. So for those who may not be familiar with how autism is diagnosed and treated today, it is diagnosed through time-consuming, expensive one-on-one evaluations between a child and a specially trained therapist. Just for context, the American Academy of Pediatrics has recommended universal autism screenings as early as 18 and 24-month well baby visits. However, due to rising autism prevalence, as well as limited number of practitioners and many other factors, unfortunately, the average age of diagnosis is still 4.5 years of age and older. And that's problematic just because the reason we really want to get children into services much earlier, just like anything in medicine with early detection can lead to early intervention. And really the 18 to 24 month time frame could lead towards taking advantage of neuroplasticity windows that are still quite open. If we could intervene even earlier than that, great. But there's some practical reasons why that's not possible today, given the current behavioral diagnostic paradigm. To make a complicated and multi-layered problem worse, and it's just like every industry, COVID-19 really starts exposing even more holes in all areas of in every industry. But for autism, given that diagnosis is made through one-on-one evaluations between child and a therapist, the autism diagnostic test that is considered the gold standard, the ADOS. If clinicians are wearing PPE and things of that sort, the test was not validated, of course, to assess children while clinicians are wearing PPE, which makes matters complicated. And then since behavioral therapy involves one-on-one interactions to try and get children to learn different ways of changing their behavior through interactions with a therapist, since those sort of interactions didn't happen at the rates they normally would, unfortunately, children in terms of the diagnosis were not being diagnosed at the rates they normally would, and the diagnoses that are happening are problematic due to the PPE, et cetera, and the therapy that children are receiving was also compromised as well. So many problems in terms of the current behavioral and treatment paradigm. So, we all are aware that we need to try and do something to move the field forward and to try and solve many of these problems. And that's why at BioROSA, we're looking to try and develop what we hope to be a universal blood test that can be used for early detection of autism through assessing very specific metabolic abnormalities. This is not a theory or hypothesis that BioROSA developed as a company. This was something that Dr. Jill James, Richard Frye, and others that I worked with at Arkansas Children's from 2010 to 2017 helped open my eyes towards. And then really that work is still ongoing, but a lot of Jill's work that she has done over the years was retrospective. It didn't really look in terms of trying to develop a diagnostic test for autism. There was considered somewhat of a breakthrough in 2017 when Jill's data that assessed metabolic abnormalities in children with autism was provided to Jürgen Hahn at RPI in Troy, New York, in which Jürgen looked to see if he could train some computer code and develop a machine learning algorithm that could differentiate autism from non-autism cases. In the studies that Jürgen did, he looked at autism versus typically developing, as well as siblings of children with autism, and saw that he could the computer algorithms could differentiate autism from the other groups with close to 90% accuracy. Given that that was pretty remarkable, and that there was still some work that needed to be done in order to clinically validate these things and try and develop a clinical and commercial grade assay, BioROSA incorporated as a company in 2018. We had some technical challenges that we had to overcome based on some of the limitations of the academic work in terms of the laboratory techniques that were used in the academic labs wouldn't necessarily be sensitive or suitable for large-scale commercial assays. So we had to develop something, and we successfully validated our laboratory approaches. And then we also realized that given that we're dealing with metabolites, which we'll get to in a few minutes, they're involved in redox metabolism, we knew that they were highly reactive and unstable. So we had to figure out new stability protocols to try and make sure that we could not have as we use in software, a garbage in, garbage out sort of data process, and actually ensure that we have a good quality signal of the data. So BioROSA accomplished those goals, and our team innovated over the past few years, and we're fortunate to get to a point where we just recently, right before Thanksgiving, launched our prospective double-blind study, which I'll talk about here in a little bit. So what we're doing is hoping to develop what we consider what we'd hope to be a universal screening test for autism that we would hope to detect autism as early as 18 months. If we could get to a point where we could detect even earlier, great. But given that the current behavioral testing through the ADOS and other behavioral diagnostic instruments our lower bound age limit, at least starting off, in order to try and show a correlation with the gold standard, needs to start with how we can currently diagnose autism today. So we are targeting 18 months of age as our starting point. As many companies in this space, or anyone that's trying to develop new biomarkers or early detection techniques for autism, we all deal with the same sort of problem. So we all start around the same age range to start. So we basically do what we do through collecting a small sample of blood from children in a standard phlebotomy setting. We are able to stabilize the blood through some proprietary ways in which BioROSA has developed stabilization techniques of our analytes of interest. The data gets shipped to our laboratory up in the Boston area, in which we've developed a liquid chromatography triple mass spec, fancy words, just a laboratory approach to being able to analyze the analytes of interest. And then those analytes, once we have our trial completed, end up going to bioinformatics to train an algorithm. And then we have a holdout set in which we validate the algorithm against our remaining set of samples. And we'll kind of talk about that a little bit later. Based on the historic research that was conducted at Arkansas Children's through Jill, Jürgen, Richard, and others, the current data has shown that the validation algorithms are performing at close to 90% accuracy in terms of differentiating autism spectrum disorder versus non-autism spectrum disorder, and that is looking at siblings as well as typically developing children. What really needs to be done and why we're doing the clinical study that we're doing is that we need to do this in a prospective double-blind study against the current gold standard. This slide just gives a little bit more context into starting with targeted metabolic analyses, looking at problems in 1-carbon folate mediated metabolism in their branch chain. That's really what Jill initially focused on, in which we saw problems in glutathione redox metabolism, problems in the methylation capacity of the cell. Folate, we've known folate super important for neurodevelopment for quite some time. And then through some of Richard's work, as well as others, we found biomarkers of mitochondrial metabolism as well that also may be abnormal in children with autism compared to other children. And this just really kind of breaks down why we need to be better at allowing for early development. You can see that where the black line is for the current age of autism diagnosis, we've really missed out on many of these key areas of neurodevelopment in which these skills are being developed by young infants. Young infants are able to develop these skills and be able to actually have significant responses to certain therapies if we're able to get children into therapies early enough. But you can see that unfortunately these windows are closing, and that if children are diagnosed here, unfortunately they've missed out on those early intervention windows in which they may have profound response to therapy. We do know that not all children have a dramatic response to behavioral intervention, and that's why we really need to not only develop and validate clinical biomarkers for early detection, but our company is hopeful that we can also leverage these biomarkers to help aid in novel therapeutics that are under development as well. But in order to get to those lofty goals, we need to start and prove out this hypothesis that redox mediated abnormalities can be predictive of autism versus not autism. And what we mean by not autism is children that are referred to a developmental pediatrics clinic for an evaluation of autism because it's believed that they may have the condition, but they're found to have other developmental problems that are not actually autism spectrum disorder, which is really the true test, right? So if we really believe that redox mediated abnormalities are predictive of autism, we need to show that it's predictive of autism spectrum and not just predictive of general developmental concerns in children. That study has never been done, and so BioROSA is the first to look at looking at redox-mediated abnormalities and 1-carbon folate related metabolic disturbances for prediction of autism. And we're very excited about the clinical trial that we just launched. And we are doing this in a prospective double-blind manner. Why? We found through our work as well as some collaborators that samples that we've looked at that what we consider retrospective in terms of children that had been involved in autism clinical trials post-diagnosis that were in a biobank. We see that if samples are not preserved in certain ways, they are very compromised in terms of being able to assess problems in redox. So we realized that we needed to, moving forward, develop ways in which we stabilize biomarkers of interest to where we have a good quality, clean signal that has not been compromised moving forward. For this particular study, we consider success to be differentiating autism from non-autism as defined by DSM-5 and ADOS criteria with at least 80% separation. And we're also doing, as we'll see in a few minutes, many other cognitive, behavioral, and medical assessments of the children to see if we can look at correlations with our autism risk score with other aspects of development, such as the Vineland, the Mullins, which is can look at receptive expressive language and also give a surrogate of IQ, as well as a few other psychometric tests. This just really breaks down what I've just stated in more of a graphic display. All children that come into the study from a pediatric waitlist will be assessed through gold standard criteria using ADOS, DSM-5, the Mullins, Vineland, and so on and so forth to either have a gold standard confirmed ASD or not ASD. We'll realize that those children will have another form of developmental concern, or maybe those children, the parents were worried, but the child may actually be, it may have been what we consider a worried well, where the child is actually found to be typically developing and not have any problems. Then we also have another group of typically developing children that we're recruiting at our clinic up in Vanderbilt University in Nashville, Tennessee. We define typically developing as children that have no history of developmental, behavioral, or clinical problems. The age range for the children in this study is 18 to 60 months. And so far, we have completed our first few patients that have been enrolled, and we look forward to having a few more before the holidays, and things are really picking up for what we've scheduled for January, which is pretty exciting. So in addition to all the standard clinical evaluations that are done on the children, we're also drawing a small amount of blood on the kids as well. And the goal is to see if our metabolite panel that looks at problems in redox, mitochondrial dysfunction, folate metabolism, can be predictive of autism as compared to the gold standard. And again, success for this particular pilot study is considered 80% accurate or greater. This just breaks down the schedule of events for the participants. You can see that on the left, for children that are receiving an ASD evaluation, there are two clinics. One is our site out in Arizona at the MELMED Center in collaboration with the Southwest Autism Research and Resource Center, or SARC. That is our Arizona site. And then we also have Vanderbilt University, that's also another clinical site. All children will receive the same evaluations and collect a little bit of blood. And then we also have typically developing children, a small cohort of 50 typically developing that we just verify as TD through a few different evaluations. We'll also look to see, as I said previously, whether there's correlations between some of these other tests and behavior, but that's TBD. Nothing that we do in our lab would be possible without our phenomenal scientific team. I am not a scientist or clinician, and I have much smarter people that have been able to innovate in our lab, and just truly, it's outstanding work. They've been able to achieve some very complex technical milestones that a lot of people thought before we started this company wouldn't even be possible. So the tenacity of this team and the dedication to try and develop an assay that can be predictive of autism in early life is I thank Marie, who is my co-founder and CSO, for her leadership from the laboratory side of things, and Sanjeev Vadrasa is our mass spec chemist that has just done an outstanding job. We have a bunch of advisors and people that help us in many key ways in the study or for the company. And I won't go into great detail, but we've got a tremendous team that assist us across the board. Special thanks to the Brain Foundation, the families that are taking part in our clinical studies, our academic collaborators at RPI, MELMED Center, Vanderbilt, Medical Mind for their help in terms of the EDC, our investors. Personally, special thanks to Richard Frye and Jill James, who without their support of me, I wouldn't have been able to be where I am in my professional career. So I'm forever indebted to them. And for the patients that we saw at Arkansas Children's Hospital for the 7.5 years that I was there, I made a commitment to those families that I would never waver and try to do something impactful for the ASD community. And I was true to my word on that. And I thank you guys for always believing in this work that Richard and his group continues to do, but also what we're attempting to do here at BioROSA. Our children and families deserve better outcomes. We need an improved standard of care. We need better ways of trying to address the myriad set of problems that are unfortunately leaving many of the children out in the cold. So at BioROSA, we're trying to do our small part in order to improve certain aspects of a complex set of problems. And I thank you guys for your attention and for the ability to speak to you here today. So with that, I'll turn it back over to Pramila.
So the next speaker is not here yet. That would be Mark.